we know we just have to be flexible. Take it away. All right. So we're ready to get started?
Yeah, it's recording. I'm just trying to
All
get the position of the screen a little bit better so they can see it on the TV.
Well, I understand that we've had some circumstances and not everybody's going to make it, but we're going to go ahead and get it recorded so that maybe we can share it with some of the public safety that was unable to come. So, good morning. I'm Marlene Vonage, and I'm here to introduce Dr. Kelly Daugherty, owner and health psychologist at the Suncrest Psychological Services in Lafayette. January's Behavior Health Awareness Month, and I'm so glad that Dr. Dean was available to come today to speak to us all, and especially the public safety. I know some of you might have only come for the snacks, but my objective to asking Dr. Dardeen here was to make her a familiar face. If you are exposed to job-related trauma, and this trauma starts haunting you, causing problems in your personal or work life, and you stop sleeping at night, or anxiety replaces your happiness, I want the public safety to know that they do have help. Dr. Dean's services are at no cost to the employee. They are confidentially billed to the city and paid under the city budget. So this is how it works. The employee would call Suncrest. They would schedule an appointment with Dr. Dardeen. Suncrest would confidentially invoice the city. The visit is kept between the employee and Dr. Dardeen. To the city, the employee is only a number on the invoice. Nobody wants to be a number. I mean, that's what we say, but in this case, this is what needs to be done. And thank you, Dr. Dardeen, for making your services available to our public safety.
Absolutely. All right, today we're going to go through a little bit about EAP, what the purpose is, how you access it. I'll give you additional data that you can use. And then we're also going to take an opportunity to talk about what are the ways you can protect yourself from exposure, right? Police and fire, EMS, those types of organizations, they're not going to be able to opt out of trauma exposure. It's part of their job. It's going to happen. And we need to help them understand what's normal, because to date, there's been a lot of misunderstandings and just lack of training as to how your body responds to trauma. So our job is to get folks more familiar and then talk about a skill set that is good for anybody to have in general to deal with stress, but specifically trauma-geared things that can help us cope when you are a first responder and you're getting repeated exposures. So real quick blurb for me. I'll try to sit down, but I'm not good at holding still while I'm talking, so we'll see how that goes. I have experience and credentials with trauma, as well as sleep disorders, as well as critical incident management. So those are things that I have spent additional time and training working on throughout my lifetime without any particular purpose in mind. But over the past 5 years, it has become more geared toward first responders. So I started out working with military folks returning from active conflicts. Learned from that population that because I'd had some experiences early in my training as an EMT, that we had some overlap in how we approached some of those experiences, and that translated really well to working with other first responder populations. So over the past 5 years, I have opened a private practice that then has grown to incorporate At this point, only first responders. So I work on contract with about 15 different agencies right now. Exclusively with those agencies, I typically don't take anybody outside of contract. And I spend my time primarily focused on trauma. How do we mitigate it? How do we respond after it happens? We have both some individual treatments that are really good for trauma, as well as some group-related interventions that we use for trauma as well. As you can see, I've got several first responder folks sprinkled throughout my family. Right now, I serve as the clinical director for 6th Alarm Peer Support, which is a peer-based team where I provide their training yearly in terms of giving them some basic helping skills. So these are area first responders that are either police, fire, EMS, dispatch, or corrections. And then they work with me at least once or twice a year in full day trainings to get their skill set up to also be peer coaches and peer helpers. So oftentimes that's the first step. If you're struggling, it's a lot easier, I think, for folks to reach out to a peer than it is to reach out to me, since I happen to be a stranger to most of the agencies. I don't get to have that one-on-one contact as much as I would like. So that's a good step to get folks started. One of the things that peer support is trained to do is to know when actual mental health intervention is needed. So they'll do good screening and let me know if somebody that they've been working with at a peer level needs a little bit higher level of care, and then oftentimes they can get to me. I also do that with the Crawfordsville Police. They have an embedded peer support team, and we're currently working on creating an embedded team that's statewide for IU Health for their flight teams. So that's going to be a larger component as we move forward, because there's not enough mental health providers in the state, and there never will be. The way things are geared, we're not ever going to meet that need. So we have to start training peers, and we have to start extending a little bit. There's also ways to maximize that within an agency. So if you are an agency head and things like that, learning to utilize post-interventions debrief, post-incident debrief, pre-incident inoculation. Like, there's a lot of training and support that we can do both pre and post-event that will help your team be more resilient. And the more we move towards those, the less there is for me individually to do. And that's the goal overall, is to get folks functioning at as high a level as we possibly can get them functioning. So I use both cognitive processing therapy and EMDR to treat trauma. Those are two evidence-based treatments for trauma. They're very good. They happen to work pretty quickly. Keep in mind, when I say quickly in mental health, we're talking 4 to 6 weeks. Whereas for most things, most people's concept of treatment is, if I'm sick, I have a virus or a cold, and I go to the doctor, I get a medication, and I feel better in a day or two. Mental health doesn't work that way, because one, we have to look at everybody's foundation. We're all unique individuals. We have different life experiences that have brought us to where we are, and we have to figure out what's going to work for you. And that's the difference. You'll see a lot of people in various forms hawking some treatment or another. Like, I did this and it worked for me. But you might find that that particular intervention worked for that person because of that person's life experiences or timing of the intervention and things like that. There is not a one-size-fits-all. So that's the problem, right? That's why we bring in mental health providers after trauma, because each individual within an agency might need something different. So we can't just come in and say, hey, do this, and your people are going to feel better. So it is a much more complex system than what we get a lot of times on the medical side of things. I also am credentialed to work with sleep disorders, so I do a lot of treatment with insomnia, sleep-wake disorders, those sorts of things that are obviously very common in first responders because they are a 24-hour agency, right? Anytime you have first responders, you're looking at wonky schedules, night shifts, swing shifts, things like that. High proportion of sleep disorders, and sleep disorders can be very impairing. They can cause a lot of depressive and anxious type symptoms that, when they're treated, and we treat the sleep disorder, all of those other mood-related symptoms go away. So they have a profound impact on your agency's wellness in general. And then I'm one of the only providers in Indiana. There's a handful, maybe 6 or 7 at this point, that are actually credentialed to do critical incident debriefs. There's a lot of people doing them. They're not necessarily doing them well. The reality is it's a very specific intervention, and it requires a lot of training and oversight to be able to do. So that's something we do when there's a big event that involves multiple people. But I want you to think about EAP is just a fancy way of saying mental health care that your employer pays for. The whole purpose behind EAPs developing is to get folks into treatment quicker because unfortunately, let's say your deductible is 3,000 or 1,500 even. If you break a leg or you have a shoulder injury or something on a run, are you likely to go get that looked at? Most of the time, people will say yes, right? There might be a few hardcore folks that say no. But typically, yes, we're going to get that addressed. But what if it's depression or anxiety? Most people are going to talk themselves out of that. It's not worth the cost. I'm just going to tough it out. All of those sorts of things happen. So we are not getting care in a timely manner when it comes to mental health because there are financial barriers that we don't apply when it's a physical issue. So this is a way to get folks in quickly, to not have to worry about those higher deductible plans, and to do it anonymously. Because again, we're working with populations that are given some pretty mixed messages about emotions and how they should feel. So oftentimes they are emotionally stunted in terms of not willing to engage in thinking about negative emotions. So this is a hard population to work with. There's a lot of stigma to overcome. There's a lot of false beliefs that having a reaction after a traumatic exposure means you're weak or you can't do your job. The reality is that we're talking about human beings, and it doesn't matter how highly they're trained. If they have a brain, they're going to have a reaction. So if we can plan for that and we can train them how to spot those things and be prepared for them, they're going to be that much more successful, right? We can never keep those bad things from happening, but we can give them tools so that when they do happen, they've got some ways to deal with it and get back to feeling themselves faster. One of the things that drives me batty in terms of working with first responders is you will hear the older guys that have been on 10, 15, 20 years saying, well, if you're in this profession, there are just things you're going to remember and carry for the rest of your life. That's not normal. You actually shouldn't be doing that. If that's happening, that just tells us there's a lot of unaddressed trauma that needs to be addressed because you should not have to carry that type of memory or experience for the rest of your life. That's separate from having a recollection of it, right? I can still look back and tell you a few runs that I went on that were trauma related, but they are not at all emotional anymore. It's an autobiographical memory. It's something that happened, but it's not in the least bit distressing. And that is what we should be shooting for, is that if we have some of these memories and things like that, they are not causing us distress. They are not impairing our relationships. They are not causing panic attacks or other physical symptoms later on down the line. So that's the benchmark we should be shooting for. So it's really important for this population that it is confidential. So the way we accomplish that is I have a verification list that I get regularly from HR that will tell me who is covered under this service. And that way when somebody calls me, I check my list. If they're on the list, they're covered. If they're not on the list, then I give them other resources. Because the reality is I can't do it the opposite way. I can't get a phone call and then be like, hey, is so-and-so covered? Because then they have no confidentiality. So I have a list that was regularly updated. If I have any questions about it, I will check first and ask for an updated list. And then I assign a number to them that stays only in my medical record, and I'm the only one that has access to the medical record. And they're seen under that label until they're done with treatment. So you guys have 5 sessions per calendar year. So if we get to the end of that time and there's still work to do, then I will talk with the person individually like, okay, what are the options? Option 1, we can always transfer over and start working under insurance if they have insurance and there's not a high deductible that would keep them from continuing that. I'm never going to end treatment for somebody because they can't pay and they need to do it differently. That's not going to happen. The other option that I have is because I work with Sixth Alarm and they're a 501c3, I can do treatment through them as well. So I can contact them and say, hey, I've got an individual who needs some ongoing treatment. They've used their EAP sessions. Would you be okay with sponsoring them? And I can keep it anonymous. They're perfectly fine with that. That's part of their mission. At the end of treatment, when treatment is complete, I just send the bill to Sixth Alarm. It's again de-identified. Patient 1 was seen 6 times. This is the remaining bill that wasn't covered by insurance, and they take over. So lots of ways to keep treatment private and keep it funded so that we don't have to worry about losing any of that in the meantime. Because you get that confidentiality, I encourage you to call me directly. You don't have to go through HR. You don't have to go through your supervisor. You can call me anytime. I'll walk you through the process of getting scheduled and getting started. We'll make it as simple as possible. Okay. There's oftentimes a lot of questions about suicidality and things like that. So safety obviously is important for a variety of reasons, but the reality is forced treatment with first responder populations is not successful. Oftentimes it has a negative impact. And so what we do is if you're having any suicidal thoughts, any at-risk thoughts, anything like that, we're going to talk about them, we're going to address them, we're going to come up with a plan together that is both keeping you safe and also helping to improve your symptoms. There is no statute in Indiana that requires treatment to happen a specific way. So for example, if you came in and said, yeah, I'm having these suicidal thoughts, I have a plan, it does not mean I have to go, oh my gosh, I have to take you to the hospital right now. I have to do something, but that burden then falls on me. I am responsible. And if something were to happen to you, and I would be found, there would be a problem with that, but it would be mine because I'm taking the liability of saying, hey, we're going to do this a slightly different way than what traditional mental health would. However, we have some statutes and things like that that we try to loosely adhere to, which again is no forced treatment, coming up with cooperative care so that we are on the same page. Sometimes that means getting a primary care provider involved to get a medication started. Sometimes that just means changing the focus of visits or the frequency of visits, things like that. But those are things that are going to happen in a cooperative nature. The other thing to think about is that this does not require a disclosure to an employer. So again, safety is going to be my concern. If I don't think you're safe on the street, we're going to have a conversation about that and what that means and how we might get that to improve. But the reality is we're not going to force things. I do, however, offer folks and help walk them through the FMLA process if they're having something get in the way where they feel like they can't be safe at work and they can't function in that capacity. Then we have options to utilize a medical leave and get them the care that they need. But again, these are things that are going to be led by the person coming in, not necessarily by me. So I don't want folks to be fearful that if they come in, it means, oh, we're going to go tell your boss things that are happening and whatnot. You still have all the same privacy protections that you would under HIPAA, even though we're not using your insurance during treatment. So that's an important concept to know. And because I have a license, I have to follow all those, right? I can't just say, well, I'm just going to do what I want because that's how I want to do it. I still have to follow all of the rules and regulations to do that. So, and I always go over that up front with everybody, and I encourage folks, if you have questions about confidentiality or safety or privacy or any of that, ask those before we start or at any time during treatment. I'm pretty approachable and we can have those discussions. I even have folks every now and then call anonymously and want to have some questions answered without really divulging their name or talking about what's going on. Completely fine. If you have questions and they might be keeping you from treatment, ask them. Let's get those out in the open so that we know what we're dealing with. When you think about mental health in general, what you all encounter on the street is going to be very different than what you see if you have a sudden mental health issue develop. Because you're dealing with a subset of the population that oftentimes is very chronic in nature and having a lot of difficulties. Whereas when we're talking about folks that are highly active, involved, things like that with a skill set, it's going to present a little bit differently. So most mental health episodes when they present can be managed within 3 to 6 months. So again, that's going to be very different than when you have these chronic folks that you've dealt with maybe even for years. We're not talking about years here. We're talking about acute mental health presentations and managing them quickly and efficiently, okay? We do like to get you on a regular schedule if at all possible. So for most of our police and fire folks, that means every other week because their rotations will make that. I don't want them coming in on their long weeks of work where they only have a day or two off anyway. So we try to work around that as well. And then, of course, psychologists in Indiana don't prescribe, so we work with other providers to get antidepressants and or other medications started if they are indicated. So we can cover a variety of things. I think a lot of people also have the misconception that if it's an EAP-related program and it's funded through their employer, it has to be a work-related issue that they're coming in for. Well, you know, surprise, we all have lives outside of work, and they might impact our work. So yeah, a lot of what I deal with ends up being trauma that's caused from their work environment, but there's also an awful lot of stuff going on in our personal life that is going to impact how we function day to day, and we have to address the whole person, not just what happens when they're at work. So we will absolutely address any of those things. So this is not an all-inclusive list, but it's a pretty decent list of the types of things that we work with regularly. I'm pretty good at knowing my limits, so if I get something that I'm not comfortable with, that either I haven't treated very frequently or I don't feel like I have enough training for, we're going to have that discussion, and I'll do my best to get you placed with somebody that does have that skill set. That does come up from time to time, and I just walk folks through how to get connected to other providers, and I help find those providers because that is also a challenge sometimes in this area. Okay. So I like to take the opportunity anytime that we can get FaceTime to talk a little bit about trauma, because we got a long way to go in terms of helping folks understand what's a normal reaction and what should we expect and how do we react after the fact. So I want you to always think about trauma as a normal reaction to an abnormal situation. Our brains are very complex, they're very advanced, they have sophisticated systems already embedded in them that are designed to look for threats to our well-being. They're scanning all the time. If you've ever walked down a creepy alleyway and the hair on the back of your neck stands up, guess what? Your brain has recognized something that is making you nervous. And there's a reason for that, and we should listen to those things. So just like we have an appendix now, and we oftentimes believe this organ is pretty useless, and we end up taking it out 9 times out of 10, it's still there. We're born with it. We can't take it away. Well, same concept exists in your brain. We have sophisticated mechanisms there that are not very useful to today's world and the things that are going on in our environment, but they're still there and they're going to be triggered. So we have to work with them and figure out what they're doing to know how to respond. So that's an important concept. If you think about it, most people in the civilian world are going to have maybe 1 or 2 exposures to a big trauma in their lifetime. First responders have hundreds, if not thousands, depending on how long they've been on the job. That's not normal. That's repeated exposure to abnormal situations, and that can make your body's system get highly sensitized to where it's over-sensing threats when there aren't any, and it just sort of goes off on its own and does things that are not predictable. So we have to be paying attention to that, and we have to be doing what we can to mitigate it. We know that there are physical responses to trauma. So for example, if you get a big call and you know it's going to be something significant, oftentimes even on the way to that event, you start to have increased heart rate, you get a little shaky, you might notice you get either little shakes or big shakes depending on how much adrenaline is dumped into your system. Well, the funny part of that is there's a cognitive component to that happens in your brain at the same time you're getting the physical reactions in your body, but we almost never talk about the part that goes on in your brain. So we have to start having those conversations, and we have to start having them more regularly. So I'm going to go through a little bit of that today. So it's important, and I'm going to say it multiple times, to recognize it doesn't matter how much training you've had. It does not matter how long you've been in your job. It doesn't matter if responding to trauma is your job. You're still a human being at the core, and your brain is going to respond to those situations because you're human. That is not a weakness. It's not something you have control over, just like you can't stop that adrenaline rush if you wanted to. You can't say, nah, I don't have time for that. I'm going to make my heart rate slow down, and I'm not going to do that. We don't have that level of control over our bodies. So you can't also block some of the trauma-related thinking processes that happen, but understanding them and working with them will go a long way towards making them better. So most everybody is at least familiar with the fight or flight response, but we very rarely talk about the freeze portion of that response. And the freeze portion is what gets to be really important. And it manifests in 2 different ways. So we've got both what we think about and our lack of ability to think during a trauma, and we also have our instincts, which sometimes tell us to run away when we're supposed to be going to a call or intervening in some way. Those are instinctual processes we can't stop, but we can learn to work with them. So for example, if we are faced with a trauma, first of all, we don't get to choose whether something bothers us or not, or whether our brain reacts to it as if it's a trauma or not. That's one of those automatic things that just happens. So your brain's going to scan whatever stimuli is in front of it, and it's going to go through its own complicated algorithm to decide, am I in danger or not? So even if the danger is not to you, you still can have a reaction to it. So that's the important thing to remember. You might come out of an incident and you might have 2 or 3 people that say, that didn't bother me at all, I have no reaction. And you might have 2 or 3 people who are really impacted. And then they start comparing things, and each group thinks something's wrong with them because they're not having the reaction the other person's having. The reality is you're going to react uniquely to your own set of life circumstances. So whether you have a reaction or not, that shouldn't be causing us distress because it's not something we can control. So knowing that is an important first step. So the freeze response is normal, ingrained, and automatic. We don't get to choose whether it happens or not. We don't get to choose whether we go into fight or flight and perceive something as traumatic or not. Our brain makes that choice for us. Then we're along for the ride. So that's an important concept. This is there for a reason. It's survival, right? If you are in a shootout or you're in a high intensity situation and you need to make reactions quickly, if you are stopping to slow down and think about each repercussion before you act, you're probably already dead. So that's important. That's why this is here. It's an instinct. Your body is going to react so that you can react quicker and potentially stay safe. That's why it exists the way it is. It's an amazing response, but because we often don't understand it and don't talk about it, it ends up causing us a lot of distress. So the chemicals involved are adrenaline, glucose, and cortisol. So that's what gives us the shakes. When we have that acute fight or flight reaction, we're going to experience all of those things. We might get a little dizzy, we might get a little lightheaded, but there's a reason our body does that. It puts those chemicals in there so that we can run faster, fight harder, and potentially ward off injury if we're injured. So your body is going to shunt blood and everything to your core so that you have more strength, and it's going to shut down your peripheral arteries so that if you are cut or injured, you're likely to bleed less. All of that is instinctual survival. But it's also doing the same thing inside our head. It is shutting down access to our larger thought processes so that we can just react. What happens, though, is that can feel really frustrating in the moment, and we can actually feel physically like we're frozen and we don't know what to do next. Now, typically, those thoughts are pretty quick, and that freeze sensation is quick, and we unfreeze pretty quickly. But when you experience it, it's uncomfortable, and you feel like everybody has noticed because you've noticed. And so I hear that frequently, like people will say, I was supposed to do this, but I froze. I didn't know what to do next. And as you go down the line, everybody had some version of it. It just might have shown up differently. And the reality is they're the only one that was aware of it. Nobody else noticed because they're dealing with their own internal stuff at the time, right? I have a lot of officers who say, but I don't want that to happen. Well, I got some bad news. We don't get that level of control, right? And we have to remind ourselves of that. It is going to happen. It's minor. It's going to not last very long, which is why we have things set up for most professions where there is a check and balance system, right? Firefighters go in a squad, and there's more than one of them usually. Officers might respond individually, but guess who they're always connected to? Dispatch, right? So even if there's a single officer on a scene, they're still connected by radio so that even if they're frozen in the moment, a dispatcher asking them a question is going to cue them out of that and get them moving again. So we're always operating on those principles. So it's really important to know that we don't get to choose whether we go into fight or flight or whether something is traumatic. It's our brain's decision, right? When you're faced with a bear, your brain's going to make an assessment that, hey, this is not a fight I'm probably going to win, and I need to get out of here. So the instinct is going to be there, whether it tells us to fight or tells us to run. If the instinct is to run, and obviously you know you can't run, you still have the power to override it and do what you need to do. But again, I think understanding that that instinct to flee does not mean you're weak or scared or that you're a coward or you shouldn't be doing your job. It just means your brain is saying, hey, the odds aren't great, so you have to look at it a different way, right? That's why we have the ability to, sometimes it is, I need to fall back and get back up. I need to fall back and do these other things because obviously the odds are not in my favor. But learning to trust that response and recognizing it's not a conscious choice, It's not about weakness or strength, and it's not about cowardice. It's just about survival. Now, the other thing that occurs when we freeze, besides just physically feeling frozen, is that our brain, because it doesn't have the full capacity to access all our thoughts in that moment, it is storing the memories from that event in a different compartment in your brain than where your normal memories are stored. It's going through a whole different structure. So what happens is after the trauma has passed and we're calm again and our heart rate is starting to come down, there will be a time when our brain clicks back on and all of those thoughts come rushing back. Because now we're not blocking them and now we have access. So where I see the problems from that is people start then second guessing or Monday morning quarterbacking their performance based on information I have now when I'm not under threat for when I was under threat. Those are not comparable situations. So learning how to recognize those thoughts and confronting those is an important step. But also, once your brain recognizes, hey, there's something in this compartment that shouldn't be there, it's going to start trying to push it into the compartment it goes into. And every time it tries to make that transition, you're going to see it or experience it in some format. So whether that is, I picture that memory again, I smell that again. This morning's incident that I was with, there was really eerie music playing in the apartment that they were in on a loop. They're going to hear that poor song for a while until it finally runs its course. And so most of the time without intervention, it will transition and make its own way across to where it's supposed to be and not really need anything fancy to get there. But there are times that they get stuck for whatever reason. Maybe that's because your stress level in other pieces of your life are really high. Maybe that particular incident reminds you of somebody in your life or you've experienced something similar. There's a lot of reasons why trauma hangs around, but it blocks that process and then we just get stuck in that loop of it constantly trying to download and it can't. And that is a really uncomfortable feeling. So when that does happen, that's when oftentimes we need a higher level of intervention. So that's why on certain types of events, we try to recommend starting with the debrief process so that we can circumvent that and make that transition easier. And then hopefully that's all that's needed, but there's a lot of times that it's not, and then we follow up after about 4 weeks. So 4 weeks is really the magic timeline that we're looking at. Within about 4 weeks of a major trauma, you should be back to your baseline. If you're not, that is the first indicator that something might be a little bit out of balance and we need to work on it. And the earlier in the process we find that and fix it, the easier the process is. The longer we wait, it just means it takes a little bit longer and a little more effort to move it. It's still never too late, but it can be a little bit more difficult to do. So what's the difference between acute stress, delayed stress, and PTSD? Time is the only difference. The reality is everything that happens immediately, the shaking, the lack of ability to think, and then thoughts rushing back later, all of that is considered normal within the first 4 weeks of an incident. If, however, it doesn't go away within 4 weeks, then we're looking at this potentially being PTSD, and we want to intervene quickly and as early as possible. So delayed stress is the one that I think trips people up the most. Most people are going to start to have their reaction on scene, and it's going to be pretty noticeable. But there's going to be a few folks who are dead calm on scene and don't have a reaction. And they come out of that maybe thinking, I'm good, that didn't bother me. And then 2 or 3 weeks later, or a few days later, or a few months later, depending on the situation, all of a sudden they have this style of reaction when nothing is going on around them. And you can imagine what kind of distress that would cause if you felt like, I'm having a good day, and then I had a flat tire, and all of a sudden I'm shaky, and I keep picturing things, and I'm inordinately angry, and I can't control any of it. So the first thing that we do when somebody has that type of presentation is to say, okay, when was the last time you had a direct exposure to trauma, and what did it look like? Because oftentimes there's some level of shock that sets in, and it's not until that shock is resolved that we start having symptoms. So that's important to remember. So again, we already talked about the shaking and things that come with the cortisol dump and the adrenaline, but there's other symptoms that we don't talk about as much. So you might hear police officers teasing each other, because they do that, about people that might have tossed their cookies on scene. The reality is sometimes you don't have control over that either. Because if your body says you need to run, it's going to trigger you to vomit because it wants you to be lighter so you can run away faster. It's pure physiological stuff. It's not, oh, that person just has a really weak stomach. That being said, sometimes people do also just have a really weak stomach and they don't tolerate that stuff. But this is what I would look at first, that it might have just been a physiological response to your body saying, oh, shoot, this isn't safe and we got to get out of here. Same with bowel or bladder control. So again, if you've been on shift for 12 hours and you haven't had time to use the restroom lately, and then something big happens, guess what? You may not have the control you want to have. And that is just a purely physiological process that happens because your brain is saying, if we're in a fight and we're injured and our bowels are somehow involved, we could get septic and die pretty quickly. So it's triggering you to eliminate everything excess so that you can survive longer. It's all survival, and we have to remind ourselves of that. And again, we've already talked about the freeze response, that our brain is going to shut down and it's going to function differently during that time because it's trying to give you more and quicker reaction times. Okay? So that's the hard part with PTSD, that everything that happens initially is normal and not pathological in any way, shape, or form. It only becomes pathological if it doesn't go away. So it's a disorder of non-recovery, not the trauma exposure itself. Every reaction that you have initially is completely normal and healthy to have based on that exposure. These are some of the symptoms that this can show up at in your life. So if you notice that, or your significant other, if you notice there's a lot of irritability or anger, as humans, we like to have control. And when we're talking about first responders, they like to have a lot of control. So the fact is, trauma causes problems because it very much has a moment where our brain recognizes that we're not in control, and that feeling of vulnerability is not positive. We respond pretty negatively to that. So that oftentimes generates a lot of anger at a situation. Why did this happen? Why did this happen to this person? We try to make sense of it. And when we can't, we're left with a lot of irritability and anger. So you might see these things, again, especially right after an event. I would tell you to look for any change from your normal. If you're normally a very light sleeper and you sleep 6 or 7 hours a night, and all of a sudden you're sleeping super deeply and you're sleeping 10 hours a day, that's a change from your normal. That might be a reaction, right? Same with your appetite. If you're normally like a stress eater and you normally eat more during periods of stress and all of a sudden you've lost your appetite, again, those are the type of symptoms I would be tuning into. What's different from your norm kind of tells you if there's something going on. The other thing to remember is trauma can, because it's forcing our brain to use structures it doesn't normally use, those structures tend to be really negative. So it can force us to have more negative thoughts. Your brain is already hardwired for more negative thoughts than positive, right? Somebody gives you, let's say you have a new outfit on and you leave the house and somebody says, oh, you look really nice. And then later the same day somebody says, you've been sleeping okay, you look really tired. Which one do you think you're going to hang on to? Most people are going to be focused on the second one. And that's normal. We need to understand that that process is there and then use that to our advantage. So when you're leaving a difficult scene or you've had a really crappy day, if you can challenge yourself to find one positive thing that you can focus on, it can help shift that process a little bit. There's no such thing as an easy button. There's no one thing that's going to make it all make sense and work better, but it's a combination of putting those efforts into place regularly. Okay. We tend to have a really uncomfortable relationship with feelings. People don't like to talk about them. They don't like to feel them. They like to shut them down or say they don't have them. Everybody has emotions. And the reality is how a feeling feels like it's going to last versus how long it actually lasts are two very different things. So I want you to think about if you had a bottle of pop and it had a lid on it, not this kind, and you shook it up and took the lid off, what would happen? It's going to explode, right? But what happens if you leave that same shaken up bottle out with the lid off for a couple days? Is it going to just keep erupting? Nope. It's going to go flat. It's going to settle down and go flat. That's how our emotions work. If we express them, we tap into them, we allow ourselves to experience them, they're going to start to immediately reduce in intensity. And they will continue to reduce in intensity as you engage with them. So unfortunately, we have a really bad habit of avoiding things that are unpleasant. And the longer we avoid, the more we're shaking up the bottle. So getting good at engaging with them when you're obviously in a safe place and it's healthy to do so, do that. Talk about it. Engage with it. Let it run its course. It will start to feel better faster than all the effort we're putting into suppressing it. Okay? So these, again, are processes that we use. For example, if you have, I recommend them on any child-related death because those are things that are so outside of the norm that our brain almost always struggles with those. So coming together, processing what happened, going over those events, but anything that's significantly out of the norm. So I typically see these for multi-fatality types of things, whether that's, accidents or other means. But we pull these out when we have a large number of people that get exposure at the same time and we know they're gonna have a reaction. So pulling them together, going through the event, specifically helping folks look for those problematic thoughts and pulling those out, those are really important steps to get healing started in a positive way. Okay. We do try to do those in a timely manner. Again, kind of the rule of thumb is you want people to be safe. You want the event to be over before you start processing it because people will have shock last a different amount of time. So on average, 1 to 3 days is the best window to shoot for. But sometimes we end up doing it outside of that window, just kind of depending on what that looks like. So there are a lot of things you can do in your day-to-day life to offset trauma exposure, or these are just good life skills for balancing your mood, anxiety, anything like that. So these are skills that everybody needs to have to some extent, and these are the things that are under our control. And that's the important part, because when it comes to trauma exposure and just our jobs, a large part of our job is not under our control. So when you have things in your life that are causing stress and they're not under your control, it helps to dial down and focus on the things you can control. And those are things like how much care you're putting in on yourself, what your work-life balance looks like, creating good support systems. And again, when it comes to trauma, especially understanding what's normal and when that process becomes abnormal or we might need some intervention. So these are the things that we always have control over in our life and the things that will help us feel better and centered if we are focusing on these things actively. So having multiple roles within your life. So I see in first responders, oftentimes they become really hyper-focused on their job. And they work overtime and they work all these extra gigs within their job. And the reality is all that leads to long-term is a faster rate of burnout. You have to have some work-life balance. You need some hobbies and friends outside of that profession that can help you put those things on the back burner for a little bit, that can help you have some sense of balance. There's also going to be times when you want to hang out with the folks who understand those experiences intimately and you can talk about that. But that can't be 24/7. So having a mixture is helpful. And people always think hobbies are extra. Like, I'll get to that when I have time and whatnot. But I want you to think about it a little bit differently. Everybody has stress, whether that's work stress, life stress, relationship stress. We all have various things that are creating negative emotions in our lives. Well, if we don't have anything else, guess what your life is going to feel like? Negative emotions and stress. If you have hobbies, positive relationships, friends that you're spending time with, in this other category, doesn't take this away, but it does help balance it. Otherwise, we know what we have. And I'll have folks that'll come in and they're like, oh, I work, 4, 10, 24-hour shifts in a month, and then I work part-time here, and I work part-time doing this. And I'm like, okay, so what do you do for fun? Well, I work at such and such. No, that doesn't actually count. Even if you really like your job, guess what? It's still work. And there's still times that particular environment is going to cause a little bit of stress. But if you're only going to work and coming home and sitting by yourself in your apartment and then repeating that process every day, there is very little in that environment that's going to cause positive emotion. And it doesn't just happen spontaneously. We don't just sit around and feel positive all of the time. In fact, there are a lot more ways to express negative emotion than there is to experience positive emotion. So we have to work those things in. So hobbies are not extra. They are functional ways to keep your balance and your mood stable. Focusing on, again, work-life balance. So sometimes the answer has to be no, I can't take on that extra thing. Sometimes I have to pay attention to that. Granted, we know that sometimes that's not an option. So it's finding that balance and figuring out what's going to work for you and your family. And learning what you're good at. So one of the reasons why I did not pursue EMS long term is I have the world's most horrendous sense of direction. You use things like north-south, I'm lost already. It's not going to happen. That is just not, I am not a visual person when it comes to that. I'm not going to be successful if that's the skill set I have to use to navigate my day-to-day. So I used to lose a lot of sleep on my 24-hour shifts because I would be at a new station and be like, oh my gosh, I'm going to have to find a location that I don't know where it's coming from, when it might come in, and I have to be the one to get us there. And I don't know any of these streets. And I would sit up and study the map for hours. And when I needed to do it, I could do it. But it does not come natural to me, and it sucks out a lot of energy. Like I would leave a 24-hour shift thoroughly exhausted because I would be so anxious that I wouldn't be able to find where I needed to go. So that's not ever going to be a good fit for me long term. So we have to learn what you're good at and then try to maximize that skill set in your work environment. And the opposite is also true. If there's something you're really not good at, knowing that and being okay with it and finding ways to work around it or not have to be in that position to use that skill set, that's a healthy application, right? Taking some control in the areas that you can. Again, trying to practice some gratitude or positivity. I do not expect anybody to just be like, oh, the world is wonderful and it's all sunshine and rainbows. But I'm saying on your worst day, if you can challenge yourself to find something good about it, you're a step ahead of the game because it's not easy. We also want to look at making sure we have a good support system. So you need people in your life that you can talk to, not necessarily just to talk to when things are bad, but when things are good too. Just having connections with other humans is a positive. We are reciprocal beings. We are meant to be connected to other people. Now, that being said, in my personal life, I'm pretty introverted, so I don't need a lot of contact to feel good. In fact, I get more than enough of that at work. So when I'm off work, you're not going to find me out and about at things. I'm going to be hunkered down in my house with a book or just one-on-one with my kiddos. I'm not going to be that social person. Some people need a high level of socialization to feel good and positive. Others need a low level. So knowing what you need and attending to that is important. Trying to get plenty of rest. So sleep is our foundation for how we manage emotion. It can be especially problematic after trauma exposure. So making sure you're using good sleep practices, anchoring a set wake time in, and other behaviors to just keep your sleep on track. Allow plenty of time for rest. Also hydration, regular exercise. If you're not doing something physical, starting something small is helpful. Our bodies are meant to move. There's a reason why they get you up immediately after a hip replacement or a knee replacement and get you moving. Our joints feel better when we're moving. Our bodies feel better. So find something that you like, that you can enjoy, and try to be lightly active. It's also a great way to dissipate those extra chemical dumps that we're getting all the time if you're in an adrenaline-filled profession. And again, coping skills are important, so we don't want to get in the habit of using alcohol or other drugs to get to sleep or to stop thinking about trauma or to relax. We need healthier ways to relax than substances. It's a very slippery slope. Once you start down that pathway, it's really hard sometimes to turn it around. So we don't want to get into that. The other thing to think about is if you are prescribed a legal benzodiazepine, those are things that we do not want to use in combination with trauma ever. Because the reality is they lower the brain's threshold to protect itself, and it can make imagery surrounding trauma more vivid. That is not what we need after a trauma exposure. So alcohol can do that to an extent, but benzos are the key culprit. So even if you have a legally prescribed benzo, let's look for an alternative if you've had a recent trauma exposure to keep that from being a more painful experience than it needs to be. And then knowing the role that your thoughts play. So oftentimes what you see manifest after trauma is people playing the what if game. What if I had gotten there sooner? What if I had done this instead of that? What if I had turned left instead of right and I wouldn't have got stuck by that train? It can take a lot of different forms, but if you are second guessing what you did, we need to recognize that that is a trauma response, and the things that your brain is putting in there are going to feel true, but they are very rarely true. I would go out on a limb and say they're never true. We want them to be true because we want to have a level of control that we did not have. And so a technique that I encourage folks to use when that happens is challenging yourself to say, one, how do you know that that's true? Because they won't be able to find any evidence for it. And instead to change the thought to say, if I had done X, Y, or Z, whatever it is that they're focused on, the outcome might have been different, but there's no guarantee that it would have been positive. Because what they're putting in their mind is, if I hadn't stopped for that cup of coffee on the way, this person wouldn't have gone into cardiac arrest. Like, we can look at it from the outside and go, yeah, no, that doesn't make sense. But in their mind, yeah, because it delayed me 2 minutes. In that 2 minutes, I could have been there and I could have prevented this. And we have to challenge them to say, that's one possibility, but not the only possibility. Also, if you had been there earlier, you could have been in the line of fire, or you could have been in an accident on the way there, or, but we have to challenge folks to not just say, if I had done this small thing differently, the outcome would have been much better. We can say that the outcome might have been different, and that's the key. All right, also trying to maintain some sense of hopefulness. It's very easy for first responders because they deal with a very small subset of the population almost 100% of the time. It's very easy for them to start thinking that the whole world works this way, and it doesn't. And so we have to remind them that there's a whole world of healthiness outside of what they see in their day-to-day, and that they have to stay engaged in that environment and keep some hopefulness that there is actually some hope in humanity. It's not going to feel like that on some days, but if we keep pushing for that. And then our brains really like things that are novel and new. So one way to help cope with trauma is to get involved with something new, maybe something you've been saving up and wanting to try. But something novel is going to help distract us and help take some pressure off our brain as it's trying to transition traumatic memories into regular memories. So having something positive to look forward to is helpful. Utilizing your time off, some of them like compete on how much time off they can save up. I'm like, that is actually there for you to take care of yourself, and time between traumatic exposures matter. So use that time. If you need a day off or whatnot, like that might be your something new, is to actually use your time off and do something positive for yourself. So those are the things that we can really get focused on that can help us, even if we're not talking about trauma exposure, we're just talking about mood management. So anytime anybody wanted to start care, it would be, all they have to do is call, email, or text. I've left pins over there and cards that have my number on it. I use my cell phone for all of the EAP related stuff because that's what I have with me all the time. Sometimes people still call the office phone. I'm just not in there every day, especially lately. So it's harder for me to get those messages. So certainly, I usually can call back the same day, if not the following day. So if you haven't gotten a call back in a couple days, make sure you double check that you're calling the 812 number, because that's something that I'm always going to have access to. The voicemail is confidential and password protected. Keep in mind, I cannot save any contacts on my phone or things like that. So I'm always going to be asking, who am I speaking to? Because HIPAA-wise, I'm not allowed to create those sorts of things in my phone. So I will always have to say, who is this? Even if you've just seen me and told me you were going to text me, I'm probably going to still say, who is this? I can't pull this up in my phone. So don't be offended if that's the case. It doesn't mean I'm not paying attention or I've forgotten what we talked about. It just means I have to confirm that I make sure I'm giving the person the right information. I typically can work people in the same week or the next week. Every now and then I get to a point where I'm a little more backed up than that, but because EAP is typically shorter term in nature and we're managing a thing and then sending folks out to continue their lives on their own, that I don't run a typical practice where I'm just constantly booked and people can't get in. So usually I can get you in pretty quickly. And then sessions can last anywhere from 30 to 50 minutes. So sometimes people are really good at talking and working through things, and it might be longer to go through that. Sometimes folks are not so tolerant of that, or they're highly anxious or whatnot, and so we keep it a little bit shorter so that we can get through more material, but just not have longer periods of time to fill. So it's really a comfort thing. And I typically try to get folks in either every week, every other week, and then as you improve and the symptoms resolve, we're going to bump you out to monthly, and then eventually have you be out on your own with just a call if you need something. So that's kind of how we transition folks. And I do have a little bit of paperwork. It's very minimal. It can all be done electronically through email, through a smartphone or whatnot, or computer. And then I have the ability to do video visits as well. And all of the trauma treatments now have been adapted so that they can also be done virtually. So if you need care and you're not able to travel, I know it's quite a trek to get to Lafayette, and especially when gas gets up to $5 and over, like that's hard for folks. So if we need to do things virtually, we absolutely can. Okay. Got some other just local resources on there, but that is it. Questions? Sure. Yeah, so the thing that actually anchors our sleep is our wake time. So the single best thing you can do for your sleep is to wake up at the same time 7 days a week, or keep it within an hour of that. That allows your sleep drive to kick in at the same time every day and build steadily over time. If you're napping, if you're waking up at different times, sleeping in by a couple hours, you are causing your sleep drive to weaken over time. So single best thing is a standard wake time. That's especially important, I think, for our night shifters who often have to flip. If you can work it out in your life with your partner that you don't flip, you're going to be so much more successful than if not. But if you do have to flip, then you want to flip it the same way every time. So you want the same sleep window anchored by the wake time every time. So every day off, you're following one routine. Every day on, you're following another. But when it's just all over the place, your body is not designed to do that, and it will always struggle. The second best thing you can do for your sleep is never to be in your bed if you're not asleep. So our brains see the world in a pattern, and they are going to work off that pattern. And if your pattern is reading in bed, watching TV in bed, laying around thinking about all of life's choices in bed and not sleeping, it thinks that's what you're supposed to do in your bed, and it will continue to do so. So if you want to shut that behavior down, you wait till you're sleepy to go to bed, till you're starting to yawn and having to fight your eyelids a little bit. You lay down. If you're not asleep within 15 or 20 minutes, you get back up and you go to another room for a few minutes. Do something lightly distracting, not anything heavier, crazy, or anything like that, just kind of chilling. You wait till you're feeling droopy again, and you lay back down. If you do that consistently and you maintain that space for sleep, it takes about 4 weeks for your brain to get that new pattern. Same with your wake time, anchoring your wake time, give it about 4 weeks, and your brain starts to get like, oh, this is the place we sleep. So those are the two biggest factors in sleep, and where people typically err the most is if they have a poor night's sleep, they think, oh, I'm going to try to go to bed early and sleep more. And oftentimes then they're trying to force themselves to sleep before they're ready, and their brain isn't going to do that. And then they're going to think, well, now I'm really sleeping crappy, so I'm going to go to bed even earlier, and the process just continues to cycle out of control. Or on the other end of things, I feel like I really sleep well towards my wake time, so I'm going to sleep in a little bit, and then it gets later and later and later, and it just constantly gets destabilized. So you want to keep that window tight. Other questions? If you have them, feel free to email, call, text. I'm pretty easily reachable, and I will respond to those and get you whatever information you might need. But don't let a fear about something keep you from treatment. If you have questions about things like that, ask them. Okay? Yeah. All right.
You know, but that's
Yes. Remember that, well, we can't control a lot of things? That's one of those things we can't control. You have